Hello, my name is Nurse Pauline RN. Hope everyone is doing good today. The topic of my video is impaired skin integrity and staging wounds. Before I get started, I'm going to ask you to hit your like button, hit your subscribe button. If you have not subscribed, please share my video. Please comment. Okay, we're staging pressure ulcers today. The first stage of your pressure ulcer is localized over bony prominences. Skin is intact, non-blanchable, erythema of the dermis. Only the dermis is involved in stage 1. Stage 2 pressure ulcer is partial thickness. Dermis and epidermis is involved. Loss of dermis, loss of epidermis, an open injury, red, pink wound with abrasion, with blister, with shallow crater. Skin is not intact. Stage 3 pressure ulcer. Dermis is missing, epidermis is missing, and we are down to subcutaneous tissue. Stage 2 pressure ulcer is full thickness, loss of subcutaneous fat, visible dermis and epidermis is lost, no bone, no tendon, no muscle seen. Stage 4 pressure ulcer is full thickness wound with bone visible, with tendon visible, with muscle visible, cartilages visible, or exposed. DTI wound means deep tissue injury. The color of DTI, deep tissue injury, is purple or maroon over localized area. It's discolored, it's intact. Skin or blood filled blister due to damage of underlying soft tissue from pressure or shear. We spoke about shearing force in our previous video. So your DTIs, when you see maroon or purple in your exam, you will always know that's your DTI, deep tissue injury. ESCHAR. For example, you find ESCHAR on the heels. There is a wound on the patient's heel, but it is completely dark, black, brown. It just covers over this heel. And you know, if you should remove all that covering, something is going on inside that wound. So your eschar is necrotic or dead black tissue found over or outside of full thickness wounds. Eschar needs to be debrided in order to be visualized. Eschar is stage 4 full thickness wound, but it has to be debrided. That necrotic dead tissue on the heel has to be removed in order for you to visualize the wound. tunneling is found only, another name for tunneling is sinus tract. Tunneling, it's a tract. It is found only inside stage 4. It looks like a tract. It has to be measured, that tract, by inserting a probe or a toothpick inside that tract. In order for you to measure, you will insert a probe or a toothpick inside that tunnel. We're calling it tunneling or sinus tract. When you feel resistance, that is the end of your tunneling. That's the end of your tunneling. We measure tunneling. You insert that probe wherever the resistance is felt. That's the end of your tunneling. We will measure the length of our tunneling and we will document tunneling. So eschar is found on the outside of full thickness wound, which is your stage 4, and your tunneling is found inside stage 4 also. Tunneling is a tract. It's a little tunnel. As soon as you see it, you can identify it. You just insert that probe and measure and document your tunneling. We also have undermining of wounds. Undermining is caused by erosion under the edges of wounds. It is caused by infection of pressure ulcers seen in bedridden patients. So undermining is caused by erosion under the edges of wound. You will swab the edges when the doctor orders culturing of the wound, and you will swab that wound to identify the bacteria. The swab will be sent to the lab. We identify the bacteria, and based on the result of the specimen, the doctor will be able to order specific antibiotics to destroy that specific bacteria. Okay, the next thing I'd like to talk about is complications of surgical wounds. You have a fresh post-op patient coming up to you. You will assess the patient for complications of wounds. First complication is called dehiscence of wound. And second, there is evisceration of the wound. Dehiscence of the wound is partial or total separation of wound edges. It is due to coughing or sneezing or vomiting. When this happens, we'll call the doctor. When the wound is separated by coughing or sneezing, you can visualize the openings, through the openings, the inside of the wound. You'll just call your doctor to come to the bedside immediately. If the patient is having any signs and symptoms of distress, call the meds team before the doctor gets there. The other complication is evisceration of the wound. This is protrusion of the internal organs through the incision of the wound. Patient coughing, sneezing, whatever. This is an emergency. When you can actually see the inside of the internal organs popping through the abdomen, it's an emergency. One nurse stays with the patient. The second nurse calls the doctor immediately. Do not leave this patient. In the meantime, you can apply moist, sterile dressings with some saline 4x4s and just place it over. Make sure you wash your hands with gloves and just place your gauze, sterile gauze, to cover this wound. We do not want it to be exposed to bacteria. So one nurse always stay to the patient and assess symptoms of distress. If the doctor does not come there in time and the patient is having serious distress, you will call the meds team. Complication of surgery, surgical wounds may be hemorrhaging, a lot of bleeding. Call the doctor stat. Registered nurse, do not change the first dressings of surgical wounds, fresh post-ops. Doctors do. Signs and symptoms of hemorrhaging: low blood pressure, systolic, less than 100. And once it gets to 100, notify the doctor. Heart rate is elevated, respiration is elevated, blood pressure is going down slowly, patient is hemorrhaging. Call the doctor to come as soon as possible. If your patient is in any distress, anxiety, shortness of breath, difficulty breathing, call the meds team as soon as possible. Another complication you'll assess for your post-op patient is warmth in the legs, swellings in the legs, redness in the legs, pain in the legs. These are signs and symptoms of thrombophlebitis. Notify the doctor as soon as possible. This patient will need to go down to X-ray to have a Doppler of the lower extremities to rule out thrombophlebitis. If you have a post-op patient and the patient, especially, if you have a post-op patient and all of a sudden the patient is complaining of chest pain, call the meds team. I've had that happen to me. My patient was having chest pain. We had to call the meds team for that patient. Fresh post-op. Patient was having sign of pulmonary embolus. Patients need to get up out of bed. Do not have your post-op sitting in bed all day. They have to get up, walking around, exercising their legs. We do not want them to have blood clots in their legs. They are not supposed to be lying down in bed. They need to walk around, go and sit in the chair until when they are strong enough to get up and start walking to the door. Maybe they say, I can't go any further. Let them go back and sit in the chair. But try not to encourage them to go back and lie in bed. You can prop their legs a little bit, put some pillows across them, and let them stay in the chair. Post-op patients are at risk for blood clots in their legs, and they should be encouraged to use their incentive spirometers at the bedside. Prevents pneumonia in their lungs because you're not getting up running around like you and me, so the lungs are not expanding, so they're at risk for developing pneumonia. Okay, that ends my wound care, skin integrity. I've made 3 complete videos today. Please go and review all my videos, and you have enough information to pass your skin integrity wound care examination. But if you do not know the nursing process, you will not pass your examination. So go back and review my videos on ADPIE, assessment, diagnosis, planning, intervention, and evaluation in order for you to be successful with your examination. Stay blessed. Hit your like button, hit your subscribe button if you have not subscribed already, and please share my video and please comment. Thank you. Have a blessed day.